So good morning. My name is Sarah Grawl. I'm the manager of the program, Cardiac Rehab and the Wellness and Prevention programs, and I'm your teacher this morning. We're going to talk about heart anatomy and function and kind of go over the nuts and bolts of how the heart works and hopefully give you an appreciation of just how amazing this little gizmo is, but also some motivation to help take care of it. I think what happens with a lot of people when they have a heart event happen in their lives that you haven't really given too much thought to the heart, but suddenly it sort of grabs your attention and now you may be quite interested in it and quite sensitive about it. So I'm going to try to cover some of the basics and some of these pieces may be things you already know, but I think it's a good time to take a refresher course and maybe you'll learn a few things as well as we go along here. So the first thing I wanted to talk about, whoops, trigger finger there, is just some facts about the dimensions of the heart, the different proportions and size elements to the heart. You've probably heard your heart is about the size of a fist. It's probably in real life more likely to be the size of a wrapped fist. This model I have here is a little bit larger than life-size model. It's probably the size of a small cow's heart. But if you can just sort of imagine this as it's positioned in the middle of my chest here, for the most part, about the size of a wrapped fist, weighs in at only about 10 ounces. So it's doesn't even weigh a pound. And part of the reason for that is because it's hollow on the inside and is sort of divided up into 4 chambers, which we'll talk about in a little bit. It's a very dense organ, very muscular. In fact, it's comprised of muscle fibers, but kind of small and pretty much situated in the middle of the chest here under the sternum. You'll oftentimes think or hear that it's on the left side of your chest. It's tilted slightly to the left, but for the most part, it's underneath your breastbone, your sternum. The rib cage provides some protection for the heart. The lungs rest on top of it. And the heart itself, flat on the bottom, rests on the diaphragm muscle, which is a muscle that helps you breathe in and out. So you all know the basic purpose of the heart, and that is to pump blood to our tissues. Now you could learn a little bit about yourself right now. You know, how fast is your heart beating? How slow is your heart beating? How many times is it pumping per minute based on your pulse or your heart rate? That's the representation of the heart contracting. And so most of you, I would guess, have a pulse that's between 60 beats a minute and 100 beats a minute. And like I said, you could find that out on your own just by finding a pulse point and counting how many beats per minute. If you did the math and multiplied those beats per minute over the course of a day, you'd come up with a figure probably around 100,000 contractions a day by this little guy, this little fist-sized 10-ounce Mighty Mite. That's its given job. That's the design for this guy, and that's what it does pretty much on a daily basis. The whole purpose behind the pumping is to deliver oxygen, which is contained in the blood, to our tissues. Now, why would that be important? Well, we can't live without oxygen. We need oxygen. All of our tissues require a continuous supply of oxygen in order to be viable, in order to function. There's really no exception to that rule. Our hair, our teeth, our bones, our soft tissues, our cartilages, everything requires oxygen in order to live. And oxygen is really delivered by virtue of, I called it the oxygenators, the lungs, which actually, through our respiration, help us take oxygen into the system and in the lungs. Oxygen molecules attached to red blood cells. The red blood cells course through a series of routes or pipes, a network of blood vessels, and the movement of that blood that contains oxygen is provided by the pumping of the heart. You can't really take one part of that trifecta away and have oxygen delivered to the tissues. You definitely have to have the oxygen factories. You definitely have to have open routes. And there's got to be some movement behind the push of blood. So they all work together very intimately in order to deliver oxygen to our tissues continuously. Now, you all know that's a fact. Because we're standing here, breathing and functioning. But just to give you an example of the critical nature of that oxygen delivery, if I were to put a tight rubber band around my little finger, in essence cutting off the blood supply to my little finger, after a couple hours or so, I would probably notice the effects of no blood flow to my little finger. I might have sort of a cold sensation. I might have some pain. It could turn a different color. The longer I deprive this tissue of oxygen, the more likely the tissue itself would become damaged and eventually die. Much like a plant that you forget to water. These are how my plants look anyway. Forget to water them and the roots dry up, and even if you try to re-water it, there's nothing to pick up that moisture. Just like if I took the rubber band off my little finger, once the damage is done, it's not going to make that much of a difference. Now, my little finger is a nice part of my body. I enjoy being able to have a little finger, but this isn't going to be something that, if I were to lose function of it, is going to be very critical to my survivability. However, if you take a more serious part of the anatomy, for instance, if blood flow to my upper extremity, my head, my upper body, if blood flow through these arteries were to stop at some point, that'd be a pretty big deal. And it'd be an immediate, serious event. So if blood flow were to stop through these blood vessels that carry oxygen to my brain, I would probably pretty immediately have an emergency, become unconscious, and the longer that blood flow was not getting to my brain, the more likely my brain tissues would suffer and start to die off. I give you that just sort of spectrum of an illustration just to again demonstrate our tissues need oxygen all the time. It doesn't matter what we're talking about. The heart itself needs continual supply of oxygen and has its own routes for that very purpose. And we'll get into that a little bit more as we go along here. So let's talk about the routing system for a few minutes. The circulatory system, if you look at the word itself, it gives you a clue as to the nature of that pipeline. The circulatory system is a continuous circular route. You have blood vessels that deliver oxygen to tissues, and you have blood vessels that bring deoxygenated blood back to the heart and lungs for reprocessing. In other words, there's no dead end or cutoff point for blood flow. It just keeps going. And that makes sense because if you think about the properties of the liquid of blood, if you were to hold a handful of blood, what would happen to that liquid after a little while? It would stick together, it would thicken up. It's meant to, the platelets in blood are meant to stick together in order to clot. And in regular life, that's a great thing if you cut yourself. The thing that prevents us from bleeding to death is that the platelets stick together and form clots, stop the bleeding. Inside the routing system itself, inside the circulatory system, that could be a very dangerous thing if blood were to just stop or be so slow that it stuck together. So that's not the case in the circulatory system, where blood is continually on the move, and that's why the system is built in a circular fashion. So this is a very simplified picture, but this gives you the idea that as blood flow leaves the heart and goes to the tissues, it doesn't just stop. It actually meshes into other blood vessels that begin the journey back to the heart and lungs for reprocessing, and this sort of circle of flow is happening all the time. This diagram is very simple. It's a little more complicated, a little more involved than what you see up there. In fact, you have a lot of routes for blood flow in your body. In the previous picture, you saw just that anatomical figure that has a lot of squiggly lines in it for indicating blood vessels. Someone estimated the mileage of blood vessels in a 150-pound human would equal about twice the circumference of the Earth in mileage. So it's estimated that a 150-pound person, if you put all their blood vessels end on end, would have about 60,000 miles of blood vessels in them. And to me, the sort of wow factor there is that that's all connected to this little 10-ounce fist-sized gizmo. In one way or another, it's either pumping with that or against it, or however you want to think about it, but that's an impressive pipeline. And that includes all the big blood vessels and all the teeny tiny blood vessels. And the big blood vessels are kind of easy to pick out. The big tubes on the heart, you can always see the aorta, which is the largest blood vessel in the body. It's this usually bright red tube that is the first route that comes out of the heart. About the size of a small garden hose, about 5/8 inch or so in diameter. And then the smallest blood vessels in the capillary beds, deep in the tissues, those are 50 times thinner than human hair, a piece of human hair. So quite delicate at the terminal ends, and then quite big in diameter in the places where the blood vessels originate. So pretty easy to pick out some of those landmarks, like the aorta in particular. This picture also gives you one of the first indications of how you can sort of determine what's happening in the heart from a function standpoint. We've color-coded pictures, models, slides up here, so that you can get an idea of what's happening. Red structures in the heart and red vessels usually indicate that there's oxygen going on, oxygen delivery or oxygenated areas. And on this picture, you can see that looks like it's on the left side of the heart is red, and these blood vessels that come off the left side of the heart, the aorta included, is also red. The red blood vessels are known as arteries. The ones that carry oxygen are known as arteries. Their counterparts that return blood back to the heart, and the right side of the heart in particular, those are called veins. And I know you've heard the two terms before, but I want you to try to always use them appropriately depending on what you're talking about. Is it a blood vessel that's carrying oxygen to the tissues, or is it a blood vessel that's returning the used up stuff back to the heart? So they're very different in their build and in their function, as you'll see here. Even their distribution, arteries, the red guys here, and veins, the blue guys, you can see it looks like you have a lot more veins than arteries, and that is the case. Arteries you can think of as interstate highways, kind of the main direct routes for blood flow, no nonsense, get there, don't mess around, don't be taking all these side routes. Whereas veins work quite passively. Veins, you could decide to take a number of side routes if you wanted, and blood would still return back to the heart. Much in the same way, if you're driving to Corvallis, you can go Peoria Road or Power Line or Highway 99. There's a bunch of different ways you could get there. I-5 would be the arterial kind of route. So if you can just kind of differentiate them in that way, and appreciate that you don't have as many arteries as veins. If we look at the build of an artery versus a vein, an artery is on the bottom here. Right away you can see there's definitely some difference in how they're put together. The artery, you can see, has a thick wall, a smaller diameter compared to the vein, which is pretty thin-walled with a very large diameter. This thick muscular wall inside of the artery actually allows it to do two very important things. One is to constrict, kind of clamp down, and the other is to dilate. These are actual muscle fibers built within the middle part of an artery wall, which give it flexibility, or elasticity as we call it. That is a very good feature on an artery, because an artery is the very thing that determines where the blood needs to go. And the determinant of that is the tension on an artery wall. If an artery is clamped down, it's diverting blood somewhere else. If it's dilated, relaxed, and opened, it's receiving a lot of blood flow, a lot of arterial blood flow. Now, why would that be a good feature? Well, we have different needs all the time. The distribution of your blood flow right now is very different than it is when you're in the gym exercising. Right now, most of your blood flow is being shunted kind of towards your core. In other words, in your periphery, in your arms and legs, those arteries are probably somewhat clamped down. Not fully constricted, but clamped down enough to encourage blood to go to the gut, where you can maintain organ function and temperature and just all of the things that allow for to meet resting needs, maybe some digestion, who knows. If the fire alarm went off in here and we had to run out of here, we'd have a different need for blood flow. We would actually need oxygen in our muscles, in our working muscles, not so much in the core. So the arteries in the core would clamp down, encourage blood flow to the periphery where it's needed. And it's needed because it's got oxygen in it, and that's what makes us function. That's what makes our muscles work. So you have all these situations in life where your needs are changing all the time. And sometimes it's just normal function. Sometimes it's kind of survival function. If you were laying hypothermic in a snowbank, the same thing would happen in your arms and legs, where there would be great constriction to shunt blood to a survivor kind of area, your core, your temperature, all that stuff. Thankfully we're not in that situation ever, or hardly ever. But the fact of the matter is, no matter what you're doing throughout the day, your arteries are tensing and relaxing all the time. Now, how would we measure that? How would we know the elasticity of your arteries? There's a simple measure that we take, and we've taken it on you guys thousands of times probably. Right, blood pressure. Blood pressure measures the tension on this arterial wall. And it's an important metric to know, because if your tension is too tight on the artery wall, you have a high blood pressure, and I'm talking about the top number, the systolic number. When the heart pushes, it's pushing against the artery wall. Does that make sense? Because the arteries are connected to the heart. So every time it contracts, it's pushing through the arteries. It's not pushing through the veins, because the veins are working on the return. So that's another reason why these have some integrity to their build, why they're a little bit tougher structures. 100,000 times a day, the heart is pushing against them. We know that when you are not under a demand situation, for instance now, if I take your blood pressure, the top number, the systolic or working number, only needs to be around 120 or less. You're not doing anything. You don't require more tension on that artery wall than about 120 millimeters of mercury. The bottom number is when the heart is in between heartbeats. So it's contracting. The top number is the push. The bottom number is the relaxation. We call it systolic, diastolic, for whatever reason. So we have a primary interest in the tension on the artery wall in all situations. We want to make sure that it's flexing appropriately, and that's why we get kind of neurotic about blood pressure. When you have a tight tube, even at a resting circumstance, let's say the top number is 140, you're just sitting there kind of chilled out. Well, then it's 140. Not only is that hard on the artery wall itself over time, but the heart has to push through that extra tension on the artery wall. So that can be an extra burden for the heart. It's already working hard. And it can also lead to damage to the artery wall itself. One thing to realize is that the very inside membrane of an artery is thin. It's one cell thick. And when that becomes disturbed, and sometimes it can become disturbed if your arteries are too tight, it can crack, and when it cracks, the stuff that's flowing through your blood, particularly fats, hangs on there. And that starts to form a plaque. And that's usually one of the first beginnings of atherosclerosis. You can't really pinpoint when that happens. You may not feel that. But once it happens, as you'll see later in this slideshow, it tends to get worse over time. So controlling the things that you can, like blood pressure, really good thing to do. And that is simply a reflection of how tense or how relaxed the arteries are. So to me, that differentiates the two quite well, too, because we don't really typically measure pressure in the veins. It's hard to do. It's not that important. We know that they're working fairly passively. They don't have a lot of pressure in them, except for perhaps the veins in my lower extremity, the veins that are trying to bring blood flow back up to my heart, are working against gravity. But they're not really working against the push of the heart, if that makes sense. If we look at the front aspect of the heart, this is where you can start to see some of the anatomical features of the heart, like the coronary arteries. If we just wanted to look at the two interstate highways on the heart, we've cleverly named them the left coronary artery on the left side and the right coronary artery on the right side. And really, from those two, you have many branches, but easy way to think of it, those are the main blood flow providers for the heart muscle itself. You can picture or see the aorta on this slide as well, and you can see the tip of the heart kind of tilting to the left here. The inside of the heart, I mentioned a little bit earlier, is divided into 4 chambers. It is hollow. You can think of the heart either like from top to bottom or right to left side. To me, it's easiest to think of it in terms of the right side and the left side because there's different functions as well as the anatomy. You have a right upper chamber called the right atrium, a right lower chamber called the right ventricle, and the same thing on the left side, left atrium and left ventricle. If you look closely at those chambers themselves, you can start to appreciate the bottom chambers, the ventricles, are beefier. They're thicker walled, they're larger, and they're built actually to generate most of the pumping force for the heart. Whereas the atrium, the 2 upper chambers, really are just holding chambers. When blood is in the atrium, it's held there just momentarily before it dumps down to the ventricles. From the ventricles then comes the push to move blood flow. So you can see the divider here, the septum in between the left and right ventricle, and then the atria left and right as well. And they're giving you a clue here as to what's happening with the colors here, the red on the left and the blue on the right. If we have these 4 divisions in the heart, these 4 chambers, it would make sense that you would need to have appropriate valves, gates, doorways, however you want to think about them, to regulate blood flow, make sure it's going in the right direction or staying put when it needs to. So you do have 4 valves. They're represented in these little circles on the slide here, and those provide that regulation. The one that separates the right upper and lower chamber is called the tricuspid valve. The one that separates the left upper and lower chamber is called the mitral valve. And then you have a valve that separates the right ventricle from the blood vessel that goes to the lungs. It's called the pulmonary valve. And you have the aortic valve, which is the doorway at the end of the aorta in between the left ventricle. It's easiest to remember you have 4 chambers in the heart, 4 valves. And it kind of makes sense that it would be put together that way. So the valves are important. You know, you could have a perfectly functioning heart, great blood flow to it, strong muscle, but if you didn't have that regulation of blood flow with the valves, you'd have trouble with the efficiency of blood as it moves through the heart. This gives you just a picture from the top here what those valves look like, and that side view as well, the 4 different names. We try to very prudently fix valve problems if we become aware of them or if you become aware of them. And there are several ways to go about that. We have valve replacement, which is just basically giving you a whole new valve job. We could also repair valves and just tighten them up, cut and paste whatever needs to be done in a person's particular situation. We don't have to always remove the entire valve and put a new prosthesis in. But that is a common surgery that we do, and that's a fairly yet invasive surgery where we have to go through the chest and in most cases cut through the sternum. These are 2 examples of replacement valves, and you can see they look like they're whole valve prostheses, and they are indeed just fit into the kind of natural spot where the old valve was and sewn in place, and then they take over the job of regulating blood flow. It's a pretty easy thing to do because the valve leaflets here respond to just the push, the contraction of the heart and the push of blood through them, or the relaxation of the heart, which is what makes them close. This simple little plastic example shows you just what I just described with the valves opening and closing with the push of the heart. That's not a true valve that we would use, but kind of represents the function of those leaflets. And then this is an actual tissue valve made from heart valve, pig heart valves sewn in a fabric ring. This would be a situation where we would remove the entire valve and put this new one in, just sew it into place. This is an aortic valve, and the size of it might surprise you. It's large, but this may be what would be appropriate for a larger man. All of the heart dimensions are pretty proportionate to size, so this wouldn't be unusual to use in terms of size. So those, just for historical perspective, we did valve surgery several years prior to attempting bypass surgery because these are fairly large objects to work with. Fairly straightforward. The problem is access, because you got to get there. But for the most part, pretty basic and straightforward type of surgery. So let's talk a minute about blood flow through the heart. I described the function of the heart, the blood vessels, the arteries and veins, that vast pipeline of 60,000 miles. If you remember from 7th grade health or whenever it was, you have about 5 liters of blood volume in your body. If you can just picture that, just to get an appreciation of how much volume we're talking about. And of course it's everywhere at any given time. I mean, it's certainly not, it is not all in your heart. In fact, what goes through the heart with one heartbeat is about a cup, about 8 ounces. That's all that circulates with one contraction. And what happens goes something like this. So all blood flow that's returning to the heart through the veins comes to the right side. You would know that because it's blue on this slide. Goes to the right atrium, which holds it just momentarily and then dumps it to the right ventricle. The right ventricle then pushes that deoxygenated blood over to the lungs. And in the lungs, the red blood cells grab onto a molecule of oxygen. They become oxygenated. Come back to the left side of the heart. The left atrium then holds this red blood, this oxygenated blood, momentarily before dumping to the left ventricle. The left ventricle then pushes with enough force to get blood up through the aorta to my head, my toes, and everything in between. And that's one heartbeat. That's one of those, let's just use 70 as an average heart rate. So that's one of those 70 beats per minute. And the way that looks is the heart actually kind of squishes itself out, almost wrings itself out like a washcloth. The contraction is this sort of figure 8 contraction where with each heartbeat, the heart is pushing blood to the lungs or out through the aorta, and as it relaxes, it's kind of sucking blood back from the lungs or receiving it from the body. Just the sheer counter pressure from contraction to relaxation just fills the heart, squeezes itself out, fills, squeezes itself out, fills. Just like if you took a empty ketchup bottle, put it in a pail of water and squeezed it. When you let go, it would fill. Sort of a closed pump system. It's a neat little design. It works perfectly most of the time. The design is perfect anyway. And fairly simple. So just to sum that up again, the right side of the heart collects all the used up blood, shifts it to the lungs, becomes oxygenated there, comes back to the left side of the heart, and the left side is responsible for pushing that oxygenated blood out to the tissues. So based on that information, if I asked you what would be the most important part of the heartbeat, if you had to narrow down one part of the heart, I know you'd all come up with this answer, that it would probably be the left side of the heart, because that's what's pushing the oxygenated blood out. And remember, at the end of the day, the only thing in life that matters is that your tissues have received oxygen. If we were to zero in and measure the performance of your heart, it's likely that we would look right at your left ventricle to make sure that that has got as much vigor, as much kick as possible. And in fact, in all of you that are evaluated for heart function, that is what we look at. We can measure it in the angiogram. We can measure it with an ultrasound of the heart. We can measure it with some treadmill tests that we do. But this, unless this is working at near full capacity, it can create problems. If this is not working or failing or weak, it can actually become kind of big, dilated, it can, it can't stop and rest. So the blood is moving through it all the time. And what happens when it's weak or tired is it can stretch. It can actually leak to the chamber behind it, which is the left atrium. Then the same thing happens there as it gets big and dilated. If it can't keep up, the left atrium can leak behind it. Well, the route behind the left atrium really is the lungs. And that's a case I'm describing a failing heart. We call it heart failure. A situation where somebody's heart is just too weak that it can't keep up with that normal output. Sounds like, a horrible situation, but it can be managed pretty well with medications and appropriate exercise and medications. And dietary precautions. Sodium in particular, people watching how much sodium they eat, because sodium makes you retain fluid, and too much fluid on a weak heart just sort of provokes that situation I described. So we'll talk a little bit about the heart's conduction system, which could be a whole another lecture in and of itself. The great thing about the heart as a muscle is it's got its own ability to conduct and pump. We don't have to think our heart through each heartbeat. Thankfully, there wouldn't be very many of us walking around. It's automated. We come with our own pacemaker, essentially, and our pacemaker is a little bundle of neurons in the right upper chamber of the heart. It's called the SA node or sinoatrial node. You may have heard the term before, sinus rhythm, when we're talking about an EKG or a heartbeat. That's a good thing. I thought it would be a good name for a band as well, the sinus rhythms. Might be my next job in life. But the sinus node is right up here in the right upper chamber of the heart, and this is our natural pacemaker. This provides heartbeats 70 times a minute, or more if you need more, or less if you don't need as many. So it sort of responds to whatever the situation is, and that's a pretty cool feature. What happens is each heartbeat begins in the sinus node, and each time the heart is stimulated, a signal is sent to the upper chambers of the heart, and then it goes to this little substation, and then the signal simultaneously goes to the lower chambers of the heart to cause all the muscle fibers of the heart to come together and whoosh, contract. Obviously, that happens quickly, more than once a second for most of us. And it is, described as an electrical conduction system, so it moves quickly like electricity. What I just described, you can actually see on paper. In fact, we see it all the time on you guys by virtue of the tracing of an EKG. This is one heartbeat as I described it, drawn on a piece of paper that's timed in a certain way with a hot stylus that just shows us that sequence of events. And the sequence of events, it's not hard to dissect that. You guys could look at your EKG and figure this out yourself. You have a pacemaker wave that precedes a big spike, which is when that conduction goes through the bottom part of the heart to cause the big contraction of the ventricles, and then there's a certain period of rest, and this is sort of the recharge wave, and the whole thing happens again and again and again, just kind of repeating itself, like one thumbprint after another. What that looks like repeatedly on a piece of chart paper is, these identical complexes, one after the other. When your heart speeds up, all that happens is the intervals shorten. When your heart slows down, the intervals lengthen. But this is what we would expect to see if your heartbeat was following a normal conduction. And that's the ideal. It doesn't happen 100% of the time. In some people, you get sort of this mischievous little hiccup every once in a while, following normal beat, strange-looking beat, normal, strange. It's easy to pick that out. This particular type of extra beat is called a premature ventricular contraction, PVC. You've probably heard that term before. Maybe you have them. Most people do have them once in a while, occasionally. Sometimes they're precipitated by stress, caffeine, stimulants, exercise. Are these dangerous? Well, if you think back to what is the whole deal here, what matters at the end of the day, that's that your heart's pumping enough to get oxygen to the tissues. If these interrupt to the extent that you're not getting good output, then they're a big deal. This particular case, we probably wouldn't get real excited about. If these came very frequently, if they came in a row, they would really interrupt the efficiency of the heart. In fact, they kind of throw the whole thing off if they come too frequently. But in this situation, this in and of itself doesn't have a great deal of clinical significance. Could just be the way somebody's wired. Another very common arrhythmia is called atrial fibrillation. I'm sure you've heard that term as well. If you look at these heartbeats and you try to match up, are these intervals exactly the same? Well, they're not. And more importantly, before this big spike in each case, is there a little pacemaker wave? Nope. There's nothing. There's the recharge wave, but right here preceding the ventricles contracting should be that pacemaker wave. We don't see it. This is one of the first things that we learn in our training for this type of work when interpreting EKGs. If you see sort of an irregular nature to the heartbeat and you can't find that pacemaker spike, it's likely to be atrial fibrillation. Now, is this life-threatening or is this a big deal? It's not super comfortable for some people. In this particular situation, this is probably still about 70 beats a minute. This person might not even really realize they're having an arrhythmia. The ventricles are still pumping. That's a good thing. That means oxygenated blood is still getting to the tissues, and about 70 times a minute. The problem with atrial fib is it's often way faster than that. Sometimes the person's just sitting at rest and their heart rate's in the 130s. Well, it doesn't need to be, heart doesn't need to be working that hard and that irregularly. So we do try to fix atrial fibrillation, and sometimes we can do that with medicines. Sometimes it takes a cardioversion with the paddles to kind of reset, retime the heartbeat. Sometimes it takes a surgical procedure where they actually burn out the extra channels. That conduction pathway can find different ways to stimulate the heart off the regular track, and the surgeon can go in and target certain areas just to burn the tissue so that that conduction impulse can't go past it. And that's called a maze procedure. This doesn't really stand for anything, but the typical pattern of burning those little places looks like a maze. If we are worried that your heartbeat just can't be trusted for some reason, I mean, you definitely have to have enough heartbeats. When we're talking about, what's the low threshold on heartbeat, it's probably 30s or so. Much lower than that, you're not going to have very much function. There's just not going to be enough juice. If we worry that you've got too few of heartbeats or your conduction system just is not very dependable, that can be addressed with just an outside pacemaker. And I don't mean outside the body. This is actually, it's outside the heart. a little device that's sewn into a little pocket in the chest wall, with a lead wire, as you can see on the slide there, that's just positioned in the heart and provides the stimulus. This little gizmo acts as a computer to kind of monitor things. In some people who have pacemakers, these are working all the time, 100% of the time. They're, 70 times a minute they're going to the heart. More if the person's exercising or less if they're not. In other cases, sometimes these are just hanging out and they'll provide a beat when needed. And we can actually tell that. There's very sophisticated monitoring methods for pacemakers where you can tell how much it's worked. Is it working 10% of the time? Is it working 82% of the time? Did it give you 5 extra beats? They can get pretty nitty-gritty about it. But this is a fairly common way to just take care of heartbeats that we don't trust, I guess would be the way to say it. I'll pass that around for you to see. There's a much more serious scenario if we think your heart is going to beat in an arrhythmia that would be life-threatening, and that would be something that would be called ventricular fibrillation. We would put a device in that would actually shock the heart, just like the paddles we use when somebody doesn't have a pulse and isn't breathing. When your heart fibrillates, and not atrial fibrillation. Atrial fibrillation is the top part of the heart quivering. The bottom part's still pumping, maybe irregularly, but it's still pumping. In ventricular fibrillation, the bottom part of the heart is quivering. Who cares what the top is doing? It's probably doing nothing. But if the bottom part of the heart is quivering, it's not pumping. And if it's not pumping in seconds, that becomes life-threatening. You have got to have oxygenated blood coming out of the heart regularly. Otherwise, you're not functioning. And the longer a person has lost their heart function, if their heart is fibrillating or has stopped, every minute that goes by, there's a 10% decrease in whether they'll survive or not. So you have about 10 minutes. And I mention that not to scare you, but to bring home the point that there's a reason why there's defibrillators in health clubs and in airports and all over the place, because if a person suffers from ventricular fibrillation and they don't have a pulse and they're not breathing, they need a shock. And luckily, most of the defibrillators that are now out in the public, you could use. You could grab it and push the on button. It would tell you exactly what to do. And if the person, for some reason, was just taking a nap or passed out or something, it's not going to shock them. But if they're dead, shocking them isn't going to hurt them. So, in fact, that's the only thing that can save many people who are in the throes of what's known as sudden death. In the clinical setting, if you have had an experience like that and survived, we are not going to take chances. We're going to put a mini defibrillator in you, much like the pacemaker, in a little pocket in the chest that has a lead wire that's anchored into the heart muscle itself, and this serves as sort of a guardian angel forever and ever. Both these devices have a battery life of 11 years or so. We just chuck them when the battery's done and put a new one in. We don't. There's no place to change the battery or anything like that. So, no, no recycling. So that's something just to be aware of. There are many ways that the heart can malfunction. The electrical system of the heart is fairly complicated. It's truly rocket science to look at all the different scenarios and how to treat them. But it always goes back to the fact that we want a trusty heartbeat, because that's what you need in order to get oxygenated blood to the tissues. So whether that's using a pacemaker as a backup or a defibrillator as a lifesaver, Defibrillators often have the pacemaker capability as well, just so you know. So, someone wanted to see a picture of the coronary arteries, and here they are. The word coronary is derived from the word crown. The coronary arteries really crown. They encircle the heart. There's plenty of them, many more than what we saw on a previous picture. You have the left coronary artery here and the right coronary artery. Think of those as those interstate highways. They are the main feeders of the heart. You have this one other main branch off the left side, which is called the circumflex. So you really could say there's kind of three parts to this tree, to these branches that feed the heart muscle. And they're all important. This route is certainly important, so is this route here. However, if we think about narrowings or blockages, if you have a narrowed artery right here, it's much more of a big deal than if you have a narrowed artery right here because of the area it serves. When we try to identify these blockages or these narrowings, we commonly use an angiogram technique where you just have radioactive dye injected into your bloodstream, into the coronary arteries directly, and then X-ray pictures are taken to see that, yes, this is a compromised area. In this example, this is the right coronary artery. It is narrowed, but there's still runoff below it. So, I mean, you'd think, well, things are cool right now. However, if this becomes blocked, you would not see any of this runoff, and that part of the heart muscle would be deprived of oxygenated blood. So the cardiologist would take this catheter out and feed it over to the left side and do the same thing to visualize the left arteries on the heart. I want to just show you a movie clip of what it looks like when arteries become narrowed. The process of atherosclerosis typically takes 2 to 4 decades to build up. It doesn't happen overnight. And it's not something that you would feel acutely after eating a package of chicken McNuggets or something. Oh, there we go. Okay. So we'll look at a cross-section of a coronary artery here and kind of appreciate how this progression occurs, keeping in mind that it happens over time. So a cross-section of one of the coronary arteries, this would show you that you have a lot of stuff flowing through your bloodstream at any given time. You have oxygen, you have red blood cells, you have hormones, you have sugars, you also have fats. And these fats are what are the culprit in irritating the artery wall and irritating it to the extent that they start to kind of glom on and build this plaque that protrudes into the diameter of the artery. Now, there's still blood flowing through this artery without problem, but we're getting more narrow as time goes by. And the problem with this material is it's pretty volatile. It's prone to actually rupturing, much like a pimple would rupture. The cap breaks and ruptures, and when that happens, this plaque bleeds, and the body tries to respond by clotting over that area. And it's actually the clot that closes off the artery and causes a heart attack. This is not likely to go unnoticed because of the very little amount of blood flow getting through there at this point. And the longer the bleed continues, the more likely this clot is going to completely close up the artery and cut off blood supply completely. So this is what you're seeing, essentially a heart attack. And that happens, 95% of heart attacks happen in that way, that the plaque bursts, the body tries to defend that by clotting it over, and it closes off the artery. What does that feel like? You may be able to tell me better than I could describe, But most people would say the symptoms can come between the nose and navel, and they may be, in the early stages, something as subtle as indigestion, or a jaw ache, or a shoulder ache, or something that just isn't quite directly pointing to the heart, but may be reflective of the heart muscle struggling. In the throes of an acute heart attack, most people will say it feels like a truck is sitting on my chest, or an elephant, that kind of thing. It's pretty unmistakable, especially if it's one of the main arteries. But it's important. Yeah, and the other thing to mention is that women can have very different symptoms. I mean, I've had people say the symptom was in my thumb. I've had people say, it was arthritis in my back. Can be. Yeah, that's good. That's a good case scenario. So what we do in that case, if you show up and we think, it's a suspected heart attack, a lot of it depends when you show up. If you show up late, remember my description of tissue in my little finger after it's been cut, the blood flow's been cut off for a while. My options for that tissue being functional are limited the more time goes by, and the same is true for your heart, much more important area. But what we can do is, in the early stages, try to get any blood flow through that area. Anything is better than nothing. And one of the first treatments that's often done in a person who has suspected blocked artery is see if we can dissolve the clot by virtue of clot-dissolving enzyme. It's sort of a Drano that we put in your through an IV that circulates and breaks up this clot, so there's a little squeeze of blood flow. Another common treatment is balloon angioplasty, which involves just putting a balloon on the end of a catheter tip, blowing the balloon up, and squishing the walls apart. This greatly improves blood flow, but this alone usually doesn't work long term. The artery just kind of narrows back down again, and we have the same problem again and again. A more common procedure is to stick a stent over the balloon, which is on the catheter, and the stent is kind of a wire mesh scaffolding. When inflated, it pushes apart the artery wall and stays there permanently to maintain an opening in the artery. Yeah, that's what it looks like open there. So a stent stays in place permanently.
They put two because my artery was so big.
Mm-hmm. They can put them end on end. They can put them in multiple targets. But what they can't do with stents yet is put them around curves or put them in arteries that are bifurcated. So as good as this looks as a easy fix, it's not for everybody. It very much depends on a person's anatomy. Stents have been around for a long time and they work great. People still have to take some long-term medication to make sure that the stent stays open and doesn't clog up again by virtue of either the healing process or atherosclerosis again. So certainly not a cure-all, but something that's less invasive than going through the chest. Why don't you click on that again? See if we can, there we go. Bypass surgery is a great way to reroute blood flow. If there's no way to balloon angioplasty or stent an artery, or you have too many targets that just need rerouting, bypass surgery is a good way to go. And what bypass surgery does is just provide a new route for blood flow over the closed or narrowed area, which you can see in these two spots here. Taking a conduit from the leg or the arm or the chest, just providing that new route. Blood is like any other fluid. It'll follow the path of least resistance. So it's going to take this preferential new route versus the blocked route. And in most cases with bypass surgery, the results are immediate improvement in blood flow. The problem is that immediate improvement is oftentimes masked by a person's chest hurts like crazy because it's been cut on so much, and the breastbone is broken, and you might have a cut on your arm, and you might have a cut on your leg. So it's quite a lot to go through, but the result is quite good. The future holds a lot of promise for additional improvements in how we treat heart problems, and as you may have read, we have a new approach that's much less invasive than bypass surgery for select cases where the surgeon can go through small incisions in the chest without opening it fully through the front. So, we have kind of yet to see how that works out, but that's a possibility that's going to make some procedures much easier for both the patient and the surgeon. We can also use medications without cutting and poking and prodding. Medications do a lot to help with the heart's workload, with the fluid, with the amount of fat circulating in your bloodstream, and with heart rhythm control as well. And just so you know, we talked about this last part, especially coronary artery disease. That is the most common manifestation of heart disease, arteries getting clogged up. But there are other conditions that can be from a congenital nature, or heart failure, which we talked about a little bit earlier too, the heart weakening and wearing out, which can also happen from a heart attack, the same process of atherosclerosis. No matter what the situation is, what the crisis is, there's a lot to be said for, what happens next and what do you do to take care of whatever your situation is. How do you best manage your heart? And we should all be on this approach to helping it and not getting in its way, because it already has a hard job. So cardiac rehab comes in pretty handy after the fact. I wish we could do a little more before the fact with folks, but I think our basic approaches are, let's eliminate what we can that's harmful to your heart, and let's focus on those things that are health promoting. You can't smoke and have good blood. It may not directly affect your heart function, but smoking is the surest way to injure your arteries. And once the arteries are injured, that leads to atherosclerosis and all of the problems we just talked about. We know that what goes in your mouth goes in your bloodstream. We know that nutrition is very much related to your heart health, and you're going to have a couple talks on that as well. And hopefully you've all seen the dietitian to kind of go over your own personal plan. And you know that we're big on exercise. You probably already figured that out. And not so much because it improves your heart function, believe it or not. It's not really directly improving your heart function. But when your body is fit, your heart doesn't have to work as hard. It's as simple as that. If you've got fit muscles, if you've got a functioning body, this is coasting. This is not having to work as hard. So there is nothing to give you more protection than regular physical activity, because of all of its effects on your other risk factors and its indirect benefits to the heart. Another thing we're going to explore is this notion of being able to manage stress and to be productive in the ways that we deal with stressors in life, because they do have an impact on your cardiovascular health. So, all in all, I'll finish with that and suggest that you just contemplate your heart and every once in a while, and remember that what you do is can both get in the way, but also can be very helpful to your heart's regular job. So I encourage you to pay attention to it, continue to pay attention to it, and help it along. And that's all.